Good evening, sir. I will be presenting a case of Mrs. SK. She is a 26-year-old unmarried female resident of Ghaziabad. She is an engineer by occupation, informant being herself, and she was admitted to hospital on 17th November and was examined by me on 21st November. She presented with chief complaint of bilateral lower limb swelling since 4 weeks and complaint of decreased urine output since 3 days.
Okay.
I would like to start my history 3 years back. I would like to start my history 3 years back in 2019 when patient had complained of multiple joint pain which was of insidious onset, moderate in intensity, involving wrist, finger and knee joint bilaterally. There was mild swelling of joints. Pain was relieved on taking medication. It was not associated with redness or any diurnal variation. There was no restriction of movements or deformity. There was no history of fever. There was no history of any urethral discharge. There was no history of conjunctivitis. There was no history of scaly pruritic lesion on skin. There was no history of blood or mucus in stool. For
Okay.
this complaint, yes, sir. For this complaint, she went to a physician and was advised to take painkillers, after which the pain had reduced, but the pain recurred after stopping medicine after 5 days. The patient also noticed a reddish rash 1 week later, which was slightly raised over the skin of nose and chin, which used to increase on exposure to sunlight and was associated with slight burning sensation.
Okay.
In view of above complaint and no relief of pain, patient again visited the physician and was advised some blood investigation. After investigation, she was told to have ANA positivity and was told to have SLE. She remembers that her routine blood tests were done and they were said to be normal. At that time, she does not recall whether her urine was tested or not.
Yeah, go on. Mhm.
She was started on oral steroid. Yes, yes. She was started on oral steroid by the name of Visolone 20 mg and tablet HCQS 200 mg twice daily. She was also advised to use sunscreen for her rash. Her dose of steroid was tapered and was discontinued after 4 weeks. With the above treatment, her rash also decreased in severity. Intermittently, patient was prescribed painkiller for joint pain and sometimes even had to take steroid when the pain was not relieved by them. Patient was then lost to follow-up since 2020. This time, patient presented with complaint of lower limb swelling, which was gradual onset since 4 weeks, which was initially present over ankle, which she noticed by tightening of shoes and seeing impression of uh, footwear on her leg. It gradually increased. It gradually progressed to both the knee over the next 15 days. On direct questioning, patient also recalls of having frothy urine since 4 weeks. There was no history of any redness or pain, diurnal variation, chest pain, palpitation, PND, orthopnea, abdominal pain or jaundice, chronic diarrhea, shortness of breath or cough. For the above mentioned complaint, patient visited the physician. She was diagnosed to have raised blood pressure and her blood and urine tests were done. She was told that she was losing protein and blood in her urine, and she was told that her renal function had deranged and she remembers the creatinine value to be around 2.1. She was
All right.
advised for a 24-hour urine protein estimation, need of renal biopsy, and referral to a nephrologist. Patient deferred biopsy in view of some family function. Meanwhile, she was started on tablet Visolone 40 mg and she was given medicine to increase her urine output. She remembers the name to be Lasix. With the above medicine, her urine output increased and pedal edema decreased. On follow-up, after 1 week, she remembers being told that her serum creatinine had increased from 2.1 to 2.6 mg per deciliter and she was passing around 2 grams of protein in her urine. Patient was advised for need of kidney biopsy.
Mhm.
Patient on follow-up complained of increased pedal edema despite continuing the medicine which she was taking previously. Patient also complained of decreasing urine output since 3 days. She was passing around 2 to 3 times per day. Patient was referred for nephrology opinion and was admitted to hospital. On evaluation, she was found to have a blood pressure of 170 by 100 mm of Hg. Her serum creatinine had increased to 4.7 milligram per deciliter. She was started on IV diuretics, and after stabilization, patient underwent left native kidney biopsy on 18th November. Post-renal biopsy, patient was stable. Patient was started on IV steroid for 3 days and was given cyclophosphamide on third day of admission.
Cyclophosphamide in what manner?
There is no history of sir IV sir.
So you may mention that.
So this was hospital course sir. Yes sir. IV cyclophosphamide.
Okay.
There is no history of any fever, weight loss, sinusitis, tingling or numbness. There is no history of hemoptysis, no history of Raynaud phenomenon, sore throat or skin infection. There is no history of prior medication or any alternative form of medicine. Past history, there is no history of tuberculosis, hypertension, diabetes, coronary artery disease or CBA. Obstetric history, she had attended menarche at the age of 12 years. She has regular menstrual history, take vegetarian diet. She has a normal sleep pattern, normal bowel and bladder function, and she does not have any addiction. Family history, she does not have any history of diabetes, hypertension, or renal disease in family. Vaccination, patient has received 2 doses of Covishield in 2021.
Okay.
So should I summarize
So
the
have you
case?
finished? You have finished with the history?
Yeah. Yes, sir. Yes, sir.
Yeah. Cool. Yeah. So summarize, and then we have some questions for you.
Yes, sir. So we have a 26-year female with history of polyarthritis and facial rash
No, you
3
must
years back.
mention married or unmarried. No, you must mention married or unmarried.
Yes, sir. 26-year unmarried female with history of polyarthritis and facial rash 3 years back, diagnosed with SLE, received course of oral steroid and HCQS, then was lost to follow-up. Now presented with complaint of bilateral pedal edema since 4 weeks and decreased urine output since 3 days. Diagnosed with renal dysfunction, proteinuria, hematuria, and hypertension. Underwent left native kidney biopsy and received IV pulse methylprednisolone and 1 dose of IV cyclophosphamide.
Right. Now, I want you to go back to 2019.
Yes, sir.
Hello. You can hear me, na?
Yeah.
Yes, sir.
So
Yes, sir. I can hear you, sir.
that time, all that she told you was that she had joint pains, that is dominantly arthralgia with some
Yes, sir.
swelling, right?
Yes,
And
sir.
facial rash
Yes, sir.
with photosensitivity.
Yes, sir. Yes,
Now,
sir.
with these complaints, of course, you don't have the benefit of her urinalysis of that time. And she did not tell you
Yes,
any
sir.
history of hypertension or renal dysfunction at that time. Do you approve of
Yes,
the
sir.
use of steroids in 2019? If yes, why? And if no, why not?
Yes, sir. I approve of the use of steroid because initially she was given medicine, painkillers, but she did not found any relief. So after that, she was started on steroids, sir.
Mucocutaneous and musculoskeletal lupus, by definition, that is, if you have excluded any serious organ dysfunction, mucocutaneous and
Yes, sir.
musculoskeletal lupus, the recommendation is not to use steroids, but there are other disease modifying drugs that are given. Apart from non-steroidal anti-inflammatory
Yes,
drugs in adequate doses, there is some other
yes, sir.
agent that is used. You are aware of it.
Yes, sir.
What is it?
Sir, hydroxychloroquine.
Hydroxychloroquine. Nowhere in any textbook does it mention that if the presentation is limited to mucocutaneous and musculoskeletal problems, should you be exhibiting steroids? And there's a reason, of course, because they have a long career ahead of them, and you
Yes.
want to
Yes, sir.
avoid steroid toxicity. You wish to bring it. Of course, you must investigate for any other organ or system involvement. But this is a message for
Yes,
the
sir.
fellows that clearly textbooks of medicine and nephrology define that in the absence of any organ or system involvement, if it's only mucocutaneous musculoskeletal problem, you do not give steroids to begin with. And 5 days of painkillers, as you stated, not good enough
Yes.
to bring relief, right?
So she was given medicine. She
No,
did
you
not tell
mentioned
five
five
days.
days of joint pains. Yeah, I mean,
Means after
painkillers for joint.
5 days of stopping the NSAIDs, again she developed pain, sir.
Yeah, so there is
She was given
no
NSAIDs
regime,
after stopping NSAIDs.
right? So there is no regime which says 5 days of NSAIDs and
Yes,
stop.
sir.
They are very good anti-inflammatory drug,
Yes, sir.
as also hydroxychloroquine. It does modify disease. And
Yes, sir.
in the absence of organ or system involvement, steroids are not recommended. I'm repeating myself.
Yes,
Okay. Anyway, so this is the rationale
yes, sir.
behind it is, like I have already told you, all steroid toxicity is
Yes, sir.
cumulative. So you want to minimize exposure to steroids where you can help it. Okay.
Yes,
Hmm.
sir.
Okay. Now go ahead. Analyze the second part. She was lost to follow up. Uh,
Yes,
she
sir.
did not give you any history of hypertension in the intervening years between 19 and 22.
No, sir. She was intermittently taking NSAIDs, and if the pain was not reduced by NSAIDs, sir, she was even taking, sir, steroid. And after relief, she used to discontinue it, sir.
So this kind of intermittency is also not going to help the patient, right? Okay.
Yes, sir.
So her presentation, talk about it. What do you think happened then?
Sir, now, sir, she has presented with she has presented with gradual onset, lower limb swelling since 4 weeks, and now also there is decreased urine output since 3 days, sir.
Right.
So,
So
how would
knowing
you
lupus,
classify it? Yeah.
yeah, exactly. So knowing lupus and the WHO classification, or what do you think is happening?
She might be, sir, developing, sir, proliferative glomerulonephritis, sir.
What, focal proliferative glomerulonephritis or diffuse proliferative glomerulonephritis? What would you suspect? I mean, look, biopsy we will do and obviously confirm or validate, whatever we think. But what do you think? Which kind?
Yes, sir.
Lupus? You can quickly tell us the classes, WHO classification.
Yes, sir. Sir,
Uh,
class 1 is minimal mesangial, class 2 is mesangial-proliferative, class 3
wo-
is focal lupus nephritis, class class 3 is focal, and class 4 is diffuse lupus nephritis, class 5 is membranous, and class 6 is advanced sclerosis.
right. So in this, the class 1, I want you to concentrate on first class 1. What is minimal
Yes, sir.
mesangial? What happens histologically?
Sir,
Unless you
histologically
understand,
on light,
uh,
yes, sir. Sir, histologically on light microscopy, it is normal, and on immune fluorescence there is mesangial deposits, sir.
without increase in cellularity,
Without increase in cellularity. Yes, sir.
right? So that is why it is class 1 and it
Yes.
is called minimal and mesangial, because you will get mesangial deposits of what? Deposits of
The immunoglobulin and complements.
good immunoglobulin and complement, right? So this is what
Yes, sir. Yes,
tells
sir.
us, along with an ANA positivity, even though light
Yes, sir.
microscopy was normal, we then diagnose this
Yes, sir.
particular person as lupus nephritis class 1. What is the management of lupus
Class
nephritis?
1. Yes, sir.
What is the management of
Sir,
lupus
lupus
nephritis?
nephritis class. So it is mainly managed for, sir. We see, sir, the activity of the disease, whether she has proteinuria or any renal dysfunction. If she has low level of proteinuria, sir, we manage the patient uh, for the extra renal lupus, sir. If patient has extra renal lupus, then only we give immunosuppression. Other than that, we optimize the patient, sir, with good blood pressure control.
No, I mean, nobody has mentioned that there is an increase in blood pressure, but of course, if there is blood pressure increase, what drugs would you choose?
Yes, sir. So, preferably, sir, ACE inhibitor or sir, ARB, sir.
Correct. So, alongside this, there is still a recommendation to use disease modification in the form of hydroxychloroquine regular doses for lupus class 1,
Hydroxychloroquine. Yes, sir.
right?
Yes, sir.
And we are still not mentioning
Yes,
steroid.
sir.
Please. I mean, extra renal, of course, if there are manifestations, I have already said, any organ or system involvement
Yes, sir.
beyond skin and
Yes, sir.
musculoskeletal. Okay. Okay. What is class 2?
Musculoskeletal. Yes. Yes,
What
sir.
happens additionally in class 2?
So, class 2 is, sir, there is mesangial hypercellularity, sir, in class 2.
In addition, there is mesangial
Yes,
hypercellularity.
sir.
Does this deserve steroids
No, sir.
by itself? Suppose there is no extra renal manifestation.
No, sir.
Yeah, so the recommendations are not to use
We
steroids
will.
even in class 2 if there is no extra renal organ or system involvement,
Yes, sir.
right? Okay, so come to class 3. So what is
Yes, sir.
class 3?
So, class 3 is
Quickly,
focal
unless you reply
lupus
quickly,
nephritis, sir.
now we will never reach anywhere. Huh?
Yes, sir. Class 3 is, sir, focal lupus nephritis, sir.
Yeah,
There is, sir,
focal glomerular nephritis is what the whole thing is. FGN is the classical
yes, sir.
WHO mention of this thing. Okay.
Yes, sir.
So what happens in this? Suppose this person with class 3 histologically showing only focal glomerulonephritis and proteinuria is,
Yes,
let's
sir.
say, 800 milligrams. What do you do? And there is no chronicity. I'm adding to this because all biopsies have to be read in terms of activity and chronicity. So what do you do then?
Activity and chronicity. Yes, sir.
So what do you do?
So this patient, if she has 800 mg of proteinuria, sir, she deserves, sir, immunosuppression, sir, because uh, it can be
No,
progressive, sir, if not
no,
controlled, sir.
no, it doesn't. It mentions very clearly if renal function is adequate and proteinuria is below a gram and there are no extra renal manifestation, class 3 lupus may initially again be tried with only disease modifying drug. Of course, if the proteinuria is heavy or
Yes,
if
sir.
the renal dysfunction is there, then you will have to. But so in class 3, there is a plus minus on immunomodulation.
Okay.
Okay? Depending on
Okay, sir.
how the
Okay, sir.
presentation up. The whole aim, I'm again repeating for all to hear, is that you try and
Yes,
minimize
sir.
the exposure to immunomodulators or immunosuppressants,
Immuno-
right? That is all. So you have
Yes,
to
sir.
choose
Yes, sir.
carefully. You have to assess properly, choose carefully. Of course, there's heavy proteinuria, more than a
Yes,
gram, and things like that. There is good hypertension, and the creatinine has just moved up to 1.6. You must then use steroids. Okay. Class
yes, sir.
4,
So, diffuse proliferative, sir.
diffuse proliferative glomerulonephritis.
Yes, sir. Yes, sir.
Yeah. So this, of course, of the all the severities mentioned, we will leave class 6 apart for now. Uh, this
Yes, sir.
deserves prima facie once you come across a patient immunomodulation. All right. What about class 5?
Yes, sir.
What
Sir,
about class
class
5?
5, sir, depending upon, sir, renal. Class 5 is membranous, sir. Depending upon the renal function and the grade of protein urea, we decide
What
for
happens into
immunosuppression.
renal function in class 5?
Sir, it can be normal, sir. Even
Indeed,
in
at
class 5, it
presentation,
can be
it is
normal, sir.
often normal. What happens to blood pressure?
Yes.
What happens to blood pressure in class 5?
So, blood pressure, sir.
It is often normal,
Often normal. Yes, sir.
right? So again, you exhibit antiproteinuric drugs and make a very careful assessment whether you wish to start immunomodulators or not. All right. What happens
Yes,
to
sir.
class 6?
Yes, sir. So in this, sir, more than 90% of glomerulus are sclerosed, sir. Sir, so we avoid any immunosuppression, sir, in this.
Good. So the whole aim of all of this exercise of revising WHO classification and when to use what is to minimize
Yes, sir.
immunomodulation, because I again repeat, they have a long course ahead of them. Dr. Ajay, your comments?
No,
Yes, sir.
I completely agree with you. The only caveat I would kind of add is that the biopsy is a one-time event that you've done now. And
Yes,
the
sir.
question that I have for you is, how would you track a patient? So let's say you have a class 5 membranous.
Yes, sir.
There is some proteinuria, let's say about a gram, and blood pressures are stable. So how would you track, and what would be the trigger for you to do additional things or to consider immunomodulation? So how would you kind of monitor those patients? Or even if it's, let's say, class 1 or class 2, and you decided you're not going to do immunomodulation, how would you track? And what in your mind would be the trigger to say, oh, something's changed, or the likely pathology inside the kidney has changed? Maybe now I need to think about something else. How would you track them?
Yes, sir. Sir, I would like to monitor, sir, the protein urea, renal function, and blood pressure, sir. If there is any increase in protein urea or declining renal functions or increasing in blood pressure, sir, I would like to
My
change
only
the
thing
treatment,
is,
sir. For the
I
patient.
would use something even more basic and more important for me. You missed that one out. So when there is active deposits, meaning endothelial or epithelial deposits, what would you see first? What would be
Yes,
the
sir.
first thing that you'll see?
Sir, I would also like to see, sir, complement level, sir.
Something
Complement-
even
Something
more
else,
nephrologist
serologically.
step high. Something even more basic.
Sir, DSDN, sir,
Hmm?
DSDNA.
नहीं नहीं stat में आ गया.
Yes, sir. RBC and urine.
RBCs and pus cells. See, you're looking for
Yes.
activity.
Yes, sir.
So the urine sediment and the urine, basic test. But if there is anyone with class 3 or class 4 or any change, so you have membranous, they shouldn't have pus cells and RBCs in urine. Anyone who has any kind of focal or diffuse will have some activity in the sediment. So when you track them and follow them, my suggestion would be to look at the urine routine.
Yes.
And make sure that on their follow-ups, they at least
Yes.
get a urine routine. A UPCR would also be important.
Yes.
To make sure that
Yes,
you look
sir.
at the urine routine. And if there is activity
Yes,
when
sir.
there was none before, that's a marker that their physiology, their pathology is changing.
Yes,
So
sir.
then that becomes a point. What do you do next? And that's, I think, a question that is going to be for the group. Someone who had class 1, class 2, or class 5, you've documented a biopsy, and now you have either cells or a positive sediment or something else. So what would you do in those situations?
No, you will repeat a biopsy.
So,
Will you or not?
or
No, sir. I would also like to see if there is any increase in protein urea, sir.
okay.
No, he just mentioned to you
So
that you have a
positive
gram.
sediment, no proteinuria. Proteinuria is the same. Sediment has gotten worse.
So then
So-
I would
And
would
they are
also
on
like
3-monthly follow-up.
yes, sir. Sir,
So
I would also like to see her renal function, sir. If there is any deterioration of renal function
okay,
or
they're on 3-monthly
sir,
follow-up.
serological
You
test.
saw their sediment. Sediment is active. Their protein is same.
Yes, sir.
Their blood pressure is same. The creatinine
Yes.
was 1. It's 1.2.
Sir, I would also like to see, sir, her complement level, her dsDNA level, sir.
Okay, they're the same as last time.
Yes, sir.
Whatever they were last time, they're the same. If the dsDNA was positive with the mesangial they're still the same.
Only on this, on the basis of active urinary sediments, sir.
Again,
We do not biopsy the. We do not again biopsy the patient, sir.
so
Only on the
this is now going to get into different nephrologists, different answers. What at least it would be is that you would need to monitor them more frequently. You want to change the intensity
Yes, sir.
of monitoring. You want to, because now you have something that
Yes,
is
sir.
telling you that the physiology is changing. You can't keep them on, oh, I'll see you next time.
Yes, sir.
And you tell them 3 months, they come back in 6 months. And by then the creatinine's already gone to 3. Right. So you would
Yes,
want to
sir.
change the intensity. Some nephrologists would say, we want to biopsy. And they would biopsy with change in sediment. There are nephrologists who have lupus nephritis patients who've had 10, 15 biopsies in their lifetime. For 15, 20 years. And there are some who will do maybe 2 in a 20-year lifespan. So I agree, but there have to be at least in a change of their pathophase, you should reassess. If the change is there and consistently different than before, you would want to biopsy because you would want to consider giving them immunomodulation before they get to a creatinine of 2 and have scarring and have lost kidney function.
Yes.
So, sir, thoughts on your end? I know different nephrologists
so-
might have different takes on this.
Yeah, so simple as this. We have made a statement that to begin with, she was class 1, class 2. Now there is evidence of activity in the
Yes, sir.
sense red cells, pus cells in the urine, with everything else remaining the same. I mean, he told you proteinuria the same, blood pressure the same, creatinine has moved from 1 to 1.2.
1.2.
Now, this is when I would like to consider getting a fresh activity score to validate my clinical observation in intensive monitoring, because there is a school of nephrologists that does believe that transformations happen all the time, and
Yes, sir.
transformations decide whether you are going to now plunge into immunomodulation, because 1 and 2 you did not immunomodulate. So it's a big decision
Yes, sir.
that you're going to immunomodulate her by giving immunomodulatory drugs. Right. Okay. So this is a big decision. So you seek the activity histologically as well to validate the clinical fact that she's now got, female should have 0 to 5 RBCs. She's got 10 to 12 RBCs. Lots of things can go wrong, and you can have 10 to 12 RBCs. Okay. Depending on how the part
Yes, sir.
preparation has been done, again, variable pus cell. So you want to see patient saying, I am fine, but you got what is called an active sediment.
Yes, sir.
You would like to see histological activity and whether there has been any transformation, because if you did not intervene in time, that one creatinine having moved to
Yes,
1.2
sir.
would quickly go down to, so intensity of monitoring, yes. So say 2 consecutive 15-day visits and she continues to show activity. I personally would rebiopsy her to see for any histological
Yes.
transformation. All right. So there is a school
Yes.
of thought that
Yes,
believes
sir.
you should do this. The whole aim is
Yes, sir.
how conservative or how aggressive you are. Unlike,
Yes.
you see this thing and you start steroids and you say, I mean, whether it was focal glomerulonephritis or diffuse, you're not bothered. In practice, people would just start steroid. No, I wouldn't do that. I wouldn't do
Yes.
that, because once you start, see, within 15 days, all symptoms are better. What do you do? When do you stop? So
Yes,
this is the whole crux of the problem. So I would look for a
yes, sir.
transformation and I would biopsy her again. All right. Yeah. So
Yes,
having now
yes,
classified
sir.
her as either 3 or 4, I know I can go with this and then manage her on monitoring based on this histological diagnosis and the activity and chronicity score.
Yes,
Hopefully, since it's a recent event, chronicity score should be low, activity
yes,
score should be high, and so it will justify my immunomodulation. Okay.
yes,
Hmm. Okay.
yes, sir.
Like Dr. Kher mentioned, there is a huge debate. I mean, there are proponents and there are opponents. So, blanket giving of
Yes, sir.
immunomodulation can land you in variable problems. You know the drugs that we use, we will come to that also. So, each one of them has considerable side effects. They're not free from side effects. In
Yes, sir.
fact, morbidity and mortality related to lupus nephritis is largely a function of drug complication and intercurrent infections. You must have read about it.
Yes, sir.
Yeah. So we try and not we try and not add to her woes. That's all I would
Yes, sir.
do. Okay. So go on. So you were discussing her
Yes,
present presentation, and we arrived at
yes.
the fact that what kind of thing do you expect on biopsy?
Sir, I expected diffuse lupus nephritis, sir.
Good.
Diffuse proliferative
Diffuse
lupus
proliferative
nephritis.
glomerulonephritis is what you suspect. I would agree with you because creatinine having moved to
Yes, sir.
2.1, 2.6, and then 4.6 with a decline in urine output.
Yes, sir.
I would like to,
Yes,
speculate that she's got a diffuse proliferative. This is not the behavior of focal glomerulonephritis. This is not the behavior of membranous, right? I
yes,
would agree totally. Okay.
yes,
So now you're going to examine her.
yes, sir.
We've covered the
What
history.
other differential would you want to keep other than diffuse proliferative? What other thing could be, because we're now gone completely into lupus, so our differential discussion has completely gone kaput. So even on lupus, what would
Yes, sir.
still be on your list as differentials other than focal /
Even in
diffuse
lupus.
proliferative? What
Yes, sir.
else could be
So I would,
possible reasons for this patient to have
sir,
worsening renal function?
the thrombotic microangiopathy, sir.
Okay, good. So
Mm.
thrombotic microangiopathy presentation of lupus. Okay, what else?
What else?
ANCA vasculitis also I would like to
Okay,
keep in mind, sir.
okay. What
Yes,
else?
sir.
Any
There
other?
is an entity called APS.
Yeah.
Yes, sir.
Would you consider that?
Yes, sir, I would like to consider. Yes, sir, I will consider that also, sir.
Yeah, like you mentioned thrombotic microangiopathy, you would also like to consider antiphospholipid
Antiphospholipid.
syndrome.
Yeah.
Yes?
Yes, sir.
And
Yes,
yes,
sir.
okay, you said lupus vasculitis is, I mean, some people do use that term. I mean, so, yeah, okay. What else? Are there conditions other than lupus where there may be ANA positivity and this kind of a presentation and renal limited disease? Though you gave an elaborate history of no other organ system involvement. For the sake of completion,
Yes, sir.
are there any other entities? Isolated kidney involvement,
Yes, yes,
ANA positivity. That you may like to order some serological tests? Because we got stuck on lupus, na? That's why
Yes.
this question is being provoked to you.
yes, sir.
Hmm.
Yes, sir.
So, bolo. any other renal limited disease where there may be ANA. See, ANA has various patterns. I hope you've read about them.
Yes, sir.
And ANA has methods of estimation. There is ELISA in AMA, and then there is ANA, and then there is indirect immunofluorescence, and the relevance is totally different. I'm sure
Yes.
you know about this. So if there is low ANA positivity, they will report ANA is positive. That's it.
Yes.
Not able to provoke him at all.
So let's say other autoimmune diseases, what kind of involvement can you see in the kidney? Any other non-lupus?
Yes, sir.
So
Sir.
what kind of involvement can you see, and what diseases can be there in someone who has an ANA positivity, but it's not lupus? Do you know of other autoimmune diseases? Non-lupus?
Membranoproliferative. The membranoproliferative glomerulonephritis.
Okay. And what other autoimmune diseases can have renal involvement?
So, Sjogren's.
Okay, so what's kind of the
Rheumatoid
involvement in
arthritis.
Sjogren's? Let's just do one.
Yes, sir.
In Sjogren's, what's the kind of involvement that you get?
छोटा सा capsule बोलो यार on Sjogren's. What all you will specifically seek from the patient?
Sir, most commonly we see, sir, renal tubular acidosis, sir.
Okay.
Oh, you straight away go to renal tubular. You won't ask patient some questions. She is not going to tell you she has renal tubular acidosis. What are the hallmarks of Sjogren's which you would like to ask her? I'm talking about she's coming on follow-up to you.
Yes, sir. So, there is, I would like to see whether she has any, if she had hypertension, if there is any worsening of hypertension.
Mhm.
Sir, I would like, so patient might also complain of muscle weakness due to hypokalemia.
Due to?
Sir, hypokalemia.
Hypokalemia. Mhm.
Yes, sir.
I say I ordered couple of other serological tests and her MPO ANCA came positive. Is it possible?
Yes, sir.
That
Yes, sir.
she has a renal limited uh, microscopic polyangiitis.
Yes, sir.
Yeah, it's always possible. Sediment there also may be active. Yes, the way her
Yes, sir.
creatinine moved,
Yes, sir.
there may be what kind of proliferation?
Sir,
Renal limited microscopic polyangiitis.
Yes, sir. Rapidly progressive renal failure, sir.
Yeah, so she may, it will depend. I mean, she may be manifesting crescents in there.
Yes, sir.
And maybe a renal limited, there may not be involvement of, other organ systems. Renal limited is known.
Yes.
So he kept telling you other autoimmune diseases. So you said Sjogren's, we accepted, happy. Okay, Sjogren's. So what I mean to say is, what he's trying to tell you is, don't limit yourself to lupus.
Yeah.
All right. Sometimes the facial
Yes.
rash can be very, very vague. It does not say S capital, L capital, E capital. There can be rashes elsewhere in the body.
Yes.
And kidney involvement. So that is why you must keep the mind open for differentials. Anything else?
Yes.
Okay, I think we can move forward.
Yeah. Examination.
Sir, on general examination, she was conscious, oriented to time, place, person. Her height is 160 centimeter. It was 54 kg with a BMI of 21.1 kg per meter square. Pulse rate of 80 per minute, regular, good volume, no radio delay or no radiofemoral delay. All peripheral pulses were present. Blood pressure of 140 by 90 mm of Hg in left arm sitting position. And it was 140 by 90 in right arm sitting position. It was 150 by 96 in left leg and 150 by 100 in right leg. Pallor, icterus clubbing cyanosis were absent. She had pitting edema. Her GVP was not raised. She did not have lymphadenopathy. Her hair, nails, skin, and oral cavity were normal, sir. In cardiovascular system examination was normal, sir. Inspection, yes, sir. She had normal RS, CNS examination, sir.
Okay.
Yes, sir.
So at the end of examination, your provisional diagnosis? Presently she doesn't have rash because you're not mentioning it.
No, sir. Presently, she did not had rash, sir.
Okay. Did you notice any alopecia?
Yes, sir. No, sir. In general examination, during hair examination, sir, she did not have any alopecia, sir.
Does she have oral ulcers right now?
No, sir. At present, no oral ulcers also, sir.
You should have also killed another bird by saying there is no evidence of any polyserositis. You understand polyserositis? Only clinical
Yes,
examination
sir.
reveal that to you. Pleural effusion,
Yes, sir.
ascites, subtle pericardial effusions can't be
Arthritis. Yes, sir.
clinically made out, but pleural effusion and ascites can be, yes?
Yes, sir.
Because you mentioned CNS is normal, so good, I accept that. I mean, that's one statement. CNS is normal. Good. Very nice. Huh.
Yes.
So there is no polyserositis.
No, sir. There was no polyceratitis.
Only edema in the lower limbs.
Yes, sir.
Okay. So Bolo abhi provisional diagnosis at the end of history and clinical examination.
Sir. I've written after. Just a second. Sir, rapidly progressive renal failure, most likely due to rapidly progressive glomerulonephritis, lupus nephritis class 4 with secondary hypertension with volume overload.
And differentials?
So in differentials, I would like to keep, sir, the possibility of, sir, thrombotic microangiopathy, ANCA vasculitis,
Okay.
चलिए Dr. Ajay, take over इसका urinalysis पे.
Sure.
Whether he's done it himself. Huh?
Sure. So exam. So the labs you've what's kind of jumping out at you? Anything?
so she has low C3, C4.
Okay.
Her ANA by indirect immunofluorescence is positive, sir, and her dsDNA by ELISA was positive. Her urine routine showed 2+ protein, 5 WBC, and 8 to 10 RBC. He had a urine protein creatinine ratio of 6.15.
So sir has really put me on the spot, so I have to put you on the spot. So the urine, did you examine or look at the sediment yourself as well?
Yes, sir.
Okay. Were there any casts?
No, sir, no cast, sir.
No casts. Okay. And the RBCs?
Yes, sir. There were RBCs, sir.
Okay. So what should we be expecting to see in those RBCs?
So they dysmorphic RBC.
Okay. So were they dysmorphic?
Yes. No, sir. I could not appreciate dysmorphic RBCs.
Okay. So how can we appreciate dysmorphic RBCs and what's kind of their appearance?
So they have a ragged margin, sir. They are seen in polarized light, sir, not in.
Okay. So do you
Polarized
Yes,
light.
sir.
No, that is not a correct answer.
yeah.
You see them in phase contrast microscopy, and there is
Phase
a
contrast.
reason why you
Yes,
use
sir.
phase contrast.
Yeah.
Tell us that. Polarized light is for something else.
Yeah.
What is phase contrast
So phase
microscopy?
contrast.
I know it won't be available to you. You would just go and see a spun urine for sediment. But otherwise,
Yes, sir.
theory at least you should know what is phase contrast microscopy.
I don't know, sir. So I have seen the images, but I don't know.
You change the phase.
Yeah.
You move the phase
Yes.
at which the light passes the slide. And what would you see? Folded RBCs often, folded upon themselves. They are no more the classical biconcave and otherwise spherical looking
Yes, sir.
RBCs, the kind that you see in urine. So
So
in phase
you
contrast, a different part is seen in
yeah.
an altered phase.
Yeah. The main advantage with the phase contrast. So when you look at it under the regular microscope, the RBCs and the fluid that they're in are in the same phase or the same plane. When you do it with the phase contrast, the RBCs pop up. And so you kind of get a halo around them. And so they now look brighter and more in your face. And so that is one. If you look at it to describe it, means I'm sure, I hope all the DNB students have kind of look up, but also actually do some of the urine sediments themselves. Will see either as Mickey Mouse ears. So you'll have a central round with two Mickey Mouse ears. That is one version of a dysmorphic RBC. Or you'll see them like a bigger circle with a small on top. So like a snowman. Those are usually the classic ones that you will see. If you see enough dysmorphic RBCs, you will see like a snowman where there's one circle and then there's a small circle, which is the dysmorphic part. Or you'll see two of them, two blebs, and that's like Mickey Mouse ears. So those are usually what you would see. And in this day and age, all microscopes have cameras. If you don't have a camera, you have a cell phone, you can put it in the eyepiece and you can take beautiful pictures of urine sediments as well. And so I would encourage everyone, it's easy to do. So if you've seen a urine, you can take a picture and you can put a slide of the urine as well. Not only will it confirm that yes, you've done the sediment and looked at it yourself, you will then over time have a collection of urine sediments that you can call your own. And then you have the story of the patient, you have the sediment, and that will then kind of hold you in good stead going forward as well. So in this day and age, it's very easy to actually collect that as well. So I would encourage people to kind of go into their lab and take a quick picture and sit down with them as well.
Yeah, so he mentioned ANA positivity, anti-DS DNA positivity,
Possibility.
which everybody says DS DNA positive. All
Yes,
of us are DS DNA positive, but we are not anti-DS
Anti-DS.
DNA antibody positive, right? All of us have double
yes, sir.
stranded DNA, no? So we should use correct semantics. What else? Do you do any other serologies?
So we can do, sir,
No, we
anti-Smith
can नहीं.
antibodies, sir.
आपने इसमें क्या किया?
सर इनमें मैंने सर ENA पैनल था सर, इसमें सिर्फ एंटी डीएस डीएनए वाज पॉजिटिव सर. जो The things which were negative, I did not include it, sir, in this, sir.
Okay. So the ENA, the rest of the ENA profile was negative. Then you have
Yes,
other
sir,
things on
yes,
the
sir.
right side, other things on the right side, which you haven't mentioned.
Yes, sir. Sir, her anti-PR3 ANCA was negative, anti-MPO ANCA negative, sir.
Ah,
Sir, viral markers were negative, sir. And sir, the tests are awaited, sir. Lupus anticoagulant, anti-beta 2 glycoprotein, IgG and IgM, and anti-cardiolipin, IgG and IgM, sir.
Okay.
okay, good.
Now
And
let's move forward. Yeah.
hemogram bata dein, so that
Yes,
because
sir.
at all times remain aware of extra renal manifestations, right?
And you put MA as a differential, so the hemogram is important for that also.
Yes, sir. Yes,
So,
sir.
So how is her hemogram?
Sir, she has a hemoglobin of 12 gram per deciliter, sir.
Okay,
TLC count were 8.6 and platelet count of 175, sir.
okay, good. Did you have the ESR? Modern physicians
Yes,
don't
sir.
look
I've
at
not
ESR
mentioned in
at
this,
all.
but we have
Hmm?
also
Tell.
done ESR was also done, sir, for her.
Okay, and her present renal functions?
Sir, 4.7 milligram per deciliter, sir.
Is her serum creatinine?
Yes, sir.
Serum proteins?
Sir, we did a sir urine protein creatinine ratio, sir. It was 6.15, sir.
That you told us. That's why I am asking serum protein.
serum protein and serum globulin.
Sir, serum protein were normal, sir, and serum albumin 3.2, sir.
Is that normal or not normal?
Serum protein was normal, sir.
No. Serum
3.2.
albumin of 2.2, is that normal for a 26-year-old female?
No, sir. It is less, sir. Less than 3.5 is not.
Correct. So, okay. So, albumin that. And globulins? You don't remember. Chalo.
I don't remember, sir.
आगे चलिए.
Yeah.
Yes, sir. The next, I have the biopsy report also, sir.
Okay. So, tell us about the biopsy.
Yes, sir. Yes, sir. In light microscopy, there were 9 glomerulus. 3 were showing crescents, of which 2 were cellular, 1 fibrocellular. Remaining showing thickening of the glomerular basement membrane with agyrophilic spikes, endocapillary hyperplasia, mild neutrophilic infiltration with no fibrinoid necrosis. There was mild IFTA in tubules and moderate interstitial inflammation. Blood vessels were showing mild arteriosclerosis. In immunofluorescence, there was positivity for IgG, IgM, IgA, C3, C1q, kappa, and lambda. And the activity index was 10 of 24, and chronicity index was of 6/12, sir.
Chronicity of 6/12. Okay. So, 3 out of
Yes,
9
sir.
had crescents, of which 2 at least were cellular.
Yes, sir.
So, what does that tell you?
It is a recent event, sir, which has happened.
Yeah, less than 50% of glomeruli showing crescents, right?
Yes, sir.
Diffuse proliferation is obvious, isn't it?
Yes, sir. She has diffuse proliferation, but less than 50% were having crescents.
Okay. And yeah, otherwise IFTA and other things do make up for activity, and so she's got an activity score of 12 out of 24. But then it is
Yes, sir.
equally weighing chronicity score of 6 out of 12, isn't it?
Yes, sir.
Okay. Now you tell Dr. Ajay, how are you going to manage? I mean, you are the nephrologist. Nobody else is deciding. You are going to decide. So you tell us, what are you going to do? You've already,
Yes,
of
sir.
course, given 3 pulses of methylprednisolone and 1 IV
Yes, sir.
cyclophosphamide. Did you calculate the dose of IV
Yes, sir.
cyclophosphamide based on her weight of 64 kilos?
No, sir. We started with sir Urolupus regimen, sir, for her, sir.
Hmm?
Okay. So how
Yes, sir.
does that work?
So we give sir 500 mg twice every 2 weekly for 3 months, sir.
Okay. And what are you
And
looking
sir,
for when you
after
do that?
the pulse, yes, sir.
Okay, go ahead. Let's first complete the regimen.
Yes, sir. And we give pulse steroid therapy followed by oral therapy, sir, of steroids, sir.
How much?
How much?
Sir, 0.8 to 1 milligram per kilogram, sir.
No, how much
We
did
start
you
with
give
8,
her,
sir,
यार?
and then we gradually.
आप बताओ ना अपने पेशेंट को आपने क्या दिया?
Sir, after the steroid, sir, we shifted her to sir tablet Visolone 50 mg, sir. Her weight is 54 mg, 54 kg. We shifted her to 50 mg of Visolone, sir. At present, she is on tablet Visolone 50 mg. She has received IV cyclophosphamide 500 mg, sir. And sir, she is on tablet Septran also, sir, for prophylaxis.
Does this or anything else also?
Yes, sir, she is on diuretics also, sir. She was on IV diuretics. Now, at present, she is on oral diuretics.
Okay.
With dose was reduced, sir. Yes,
Okay.
sir. And we have included, sir, an ACE inhibitor also, sir.
Okay. Anything else?
Yes, sir.
Anything else or only these three things? These four things. We talked about endoxin, steroid,
Endocrine.
Septran, and ACE
Septran.
inhibitor.
Yes, sir.
And diuretics, you said.
Yes,
And
sir.
diuretics. Yes. So 5 things or
Yes, sir.
anything else also?
And sir,
Anything else?
tablet hydroxychloroquine also, sir.
Okay. So HCQS. Anything
Sir,
else?
tablet hydroxychloroquine. Yes,
Okay.
sir.
Anything else that you would want to put this patient on? Or anything else that you would be worried about in 3 months, 6 months, and some things you might be worried in 1 month?
6.5 grams protein, don't forget. Then think of it. You may not have given her, but are there anything else that need to be given?
Yes, sir. Sir, to avoid, sir, risk of thrombosis, we can give antiplatelet and statin also, sir.
Okay, so you biopsied her on 18th and on the 21st, you want to add aspirin?
No, sir. At present, not now, sir. For further.
Okay. अभी आपने आज की तारीख में
Yes, sir.
50 mg वाइसलोन दिया और 500 milligram endoxin दिया. Any other infections that you would be
Yes,
worried
sir.
about other than PCP, for which you've put her on Septran?
Yes, sir. Vaccination also I will plan, sir.
Okay, for what?
Pneumococcus.
Okay, अभी दोगे
Yes.
after the endoxin or?
No, sir. Not now, sir.
ठीक है. अभी क्या दोगे? आज कल परसों में क्या दोगे? Any other infections that you've seen people who are on endoxin and 50 milligrams of steroid?
Yes, sir. Sir, cytomegalovirus, sir.
Okay. Anything else? So you want to put her on valganciclovir?
No, sir.
Okay. Infections that you see
Sir,
when
we
you
would
give.
also see for.
Hmm?
Yes, sir. Sir, for if there is any, there is a possibility she can have oral thrush, candida
Okay.
infection, sir.
Good.
What do you want to do for that?
Sir, candid mouth pain, sir.
Okay. So when you give steroids, I
Yes,
think
sir.
candid would be a reasonable thing to add.
Yes.
Yes, sir.
In 3 months and 6 months, what is 50 milligrams of steroid going to do to her?
Sir, we would also add, sir, calcium and vitamin D supplements.
Exactly.
Osteoporosis.
Absolutely.
Yes, sir.
So you would want to kind of add those as soon as you kind of start, and I would hope people kind of, whenever they do you anticipate that this person is going to need immunosuppression and steroids for some significant period of time, you add those automatically. Last one would be
Yes, sir.
some kind of antacid, probably. Again, each
Yes,
nephrologist
sir.
would have a different take on which one you want to do, whether an H2 blocker or a PPI, some kind of additional, especially at a dose of 50 milligram, may be worthwhile kind of considering as well. And then
Yes.
you would want to warn them for side effects.
What all will you explain to her? These things may happen, and
Yeah.
so just observe them, tell us, but don't worry about
she-
it. These
Yes.
happen. In
So
other
she
words,
will need
run through
regular
the
blood sugar
steroids side
monitoring.
effect.
Sir. Yes, sir. So she will need, sir, blood sugar monitoring, sir, regularly, sir.
True. That is true. That you are going to monitor, na, your hospital lab, or you will order.
Yes,
I
sir.
am saying you have to reassure the
Yes,
patient
sir.
so that she doesn't drop out of her treatment regime.
Yeah.
So you will tell us some things will
Yes, sir.
happen. You said, Dr. Ajay Kher said. So how will you explain to her
Yes,
what
sir.
counseling?
Sir, she
And she's a young unmarried female. So
Yes, sir.
that's,
She can
yeah,
have, sir, cosmetical problems like acne. There can be hirsutism, sir. There can be weight gain also, sir.
Mooning of the face, buffalo hump,
yeah,
abdominal striae,
Yes, sir.
all of these are considered minor
Yes, sir.
adverse effects. These happen, and once you tail the steroids off, they also tend to
Yeah.
disappear. So you will have to reassure her.
Yes,
Otherwise,
sir.
altered self-image will make her
Yes, sir.
drop out of her treatment.
absolutely. And these are minor for us.
Yes, sir.
They may not be minor for her.
Not for the patient.
Yeah.
Yes, sir.
So on our list, they are minor, but for her, they may be major. What if, let's say, the family, what other things would you tell the family that they might need to tell you? The patient might not pick up on. At 50 milligrams or 60 milligrams of prednisolone, things that might happen.
Yes, sir. She can have, sir, mood disorders. She can have depression,
Exactly. Yeah.
sir.
And so you would need to warn them. They might be psychotic or mood issues or sleep issues that might happen. And so they may not realize it, they may not bring it up to you. But if you warn them upfront that these might happen, and if they happen, let us know. Then that might give them the confidence to come back to you at next visit and kind of tell you that this is happening. And so can you help us with it? And so that might change your taper, and that might change your approach to other medicines that might be needed with them. So those are again important to kind of
Yes.
do or talk to the patient and the family, kind of start these things.
Sir, one last question from me, because we've gone past 7:30. So one last question.
Yes.
How can you minimize the gastric side effects of prednisolone, oral steroid?
Sir, yes, sir. Sir, she should take the steroid. Patient should take the steroids, sir, after breakfast, preferably not on empty stomach, sir. So
Okay, one. And what
there
time?
should be an antacid also. So morning time, sir.
No, antacids.
So single dose morning time, sir.
No, not all my patients have required antacids, I assure you. If they finish breakfast by 7:30 and have their oral
Yes.
steroid at 8 to match with the
Yes, sir.
biological clock in the body, you can minimize a lot
Yes,
of
sir.
side effects. Okay. The breakfast would have
Yes,
nicely
sir.
layered the stomach and would be planning to now leave the stomach. And so that time, so not necessary to always require proton pump inhibitors or H2 blockers, because you've been now reading
H2 blocker.
increasingly about what PPIs do. And you also have been reading how ranitidine is now
Interstitial.
a suspected drug,
Yeah.
isn't it?
Yes.
So we try and
Yes,
conservatively
sir.
manage. And you say, if you still have a problem, let us know. And yes, we can. No, we can. So that is
Yes,
how
sir.
you can help
Yes,
the
sir.
patient. All right.
Yes,
So
sir.
I have actually finished. We've more or less covered the treatment. There are so many regimes and why, what, and all that. We couldn't reach there, but that's all right. I mean, we can discuss them another time. Okay.
Yes.
So, Ajay, I'll leave the students to you.
Sure. No, I think we are very much all caught up. I think now the main question is mostly going to be how do you follow them up, and then how do you taper
Yes.
immunosuppression. So I think that's kind of what is left, and less studies on that, and more opinion and guidance, which is based on experience rather than actual evidence for
Yeah,
it.
you can actually give them a task of having their own personal compendium of famous trials, famous ones,
Yes.
the
Yes.
important ones, you know. So, like the lunar and so on. I mean, you can tell them that these are the important ones that examiner is likely to ask you, and you should also know, even otherwise, as a conscientious nephrologist
Yes.
who treats a lupus patient. है ना? So
So
if
the
they write it down somewhere and keep when they glance through them from time to time, it will stay with them.
especially the ones that you are actually employing yourself. So if
Yeah.
you're following the Euro lupus, then you need to be completely thorough with the Euro lupus trial itself on
Yes.
what they did, what were the inclusions, what were the exclusions, what kind of patients were there in that trial. So you
Mm.
don't apply those studies. You may expand the horizon. But you do it with a knowledge base or a caveat that, okay, these were the kind of patients that were in the trial. I'm expanding it to this person also, but they were not in the trial. So that kind of evidence should be something that, especially the protocols that you are applying. So if you're
Right.
on the Euro lupus kind of protocol, what were the kind of patients that were in there? So that's
Uh,
very important.
what percentage of SLE gets lupus nephritis? Any rough guesses?
Sir, almost
Standard test.
50% of patients.
How much?
Sir, almost 50%, sir.
Yeah,
50%,
so
sir.
40 to 50% of them do get lupus nephritis. Of these, on treatment, what percentage end up in end stage kidney disease?
Sir, 10 to 15%, sir.
Good. So that is a nice answer. That is correct. If they manage properly, about 10 to 15% will still reach end stage kidney disease. Good. So I've finished with you all. Thank you very much for your participation. And thank you, Dr.
Okay.
Ajay. It was a
Thank
pleasure
you,
to
sir.
be with
Thank
you
you,
again.
sir. No. I think we had a good class. Very good job, Anish, overall. And I think we can kind of finish up here. And the target or the homework, as Dr. Umesh already said, is to take the major trials as well. And in lupus, there have been quite a few. So especially the ones that we are using for specific dose regimens and dose guidance. And so in this case, you've already decided endoxin. So the question would be
Yes.
alternative therapies that you could do instead of endoxin. Which would
Right.
those be?
So mycophenolate
Especially in view
mofetil,
of
sir.
age and all. है ना?
Exactly. So in a 20-year-old female who is unmarried, there could be physicians who would have a discussion, and you should have a discussion with her about a couple of things, especially if you're doing endoxin. What should that be? One is endoxin versus MMF. If you're giving endoxin, what kind of thing or what should you offer to her as well?
Yeah.
Sir,
Thank
as
you.
there is chance of infertility, sir.
Yeah. So what would you want to offer?
Sir, cryopreservation, sir.
Yeah, so you might want to offer her that. There may be some patients who might be able to get that done. The problem is mostly that timing in diffuse proliferative, you don't have too much time waiting to give the endoxin.
Yes, sir.
So that's kind of something. If you knew about it in 2019 and you tell them then that, yes, you have mesangial or mesangial proliferative, you're at risk. Let's get something frozen then. in case we ever need to use endoxin. So that might be kind of worthwhile doing. At this pace, when you're already in proliferative with a creatinine of 4, there isn't enough time to wait around. So, so the question would be endoxin versus MMF with the risks discussed. So I think that is something. And again, you want to keep in your armamentarium for the exam. What are the MMF trials? What are the endoxin trials? And then what's the evidence behind it? So that you can kind of compare and contrast, and then you should know which one would you want to give and why, or which one would you want to give for what kind of patients and why, so that you have your justification all set up. And when the examiner gets to that point and asks that question, you are all set. Because lupus and lupus nephritis is very high yield in theory as well as in the practical. So you will end up getting there. If you have your trials on the tip of your fingers, you can put it on paper or you can put it in the practical. I think those are important trials to kind of keep in hand. So I think we'll take it at this point, and if anyone in the audience has questions for Anish or comments. And if not, then we'll call it quits here. Okay.
Sir, there is one in the chat box, sir.
Okay. So I don't know what F testing is. Roll off. Manish will have to MMF AUC or yeah. I haven't done MMF AUC either for transplant or for lupus. So at present, you try and target 2 to 3 grams depending on what your patient tolerates, and then you kind of go with that, whatever they tolerate. So I think that's usually I've been able to get to 2 to 2.5, rarely get to 3 grams for our Indian patients. But that's kind of I haven't seen anyone use AUC, at least in actual clinical practice. Yeah, voclosporin's hot, but I'm not sure if anyone's used it here in India and what their experience has been. Tacrolimus is available, and people have used tacrolimus as well based on the Hong Kong experience. So I think that in a multimodal attack with tacrolimus, MMF, and prednisone. So based on the Hong Kong experience, people have been using it for class 4, class 3, class 4 patients. So I think that's definitely there, and voclosporin trials are out. So that's something which is available, but I haven't used it here yet. So okay. Okay, then thanks, Anish, and we'll see you next time.
Thank you, sir. Thank you so much
you.
for sparing your time.